Welcome to the Heart of Healthcare podcast. I'm Halle.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the Heart of Healthcare podcast. This is our monthly digital health download where we share and discuss the biggest headlines in the space. And per usual, there were tons of headlines to choose from. Steve, I'll let you kick it off.
Halle, happy May, right? May flowers. I always love it around my neck of the woods. It's definitely getting warmer. Well, I want to start off this month with something I've been thinking a lot about that affects a lot of our companies. You know, we on this podcast talk a lot about politics and public policy, particularly because healthcare, as we know, is the majority of payment is driven by the government, right? And so it very much is always in the news. And what's interesting that I've been reflecting on is, you know, we live in the new Trump world, right? And lots of things are being reshaped. And I think lots of prior assumptions that we had and priors that we had about how our healthcare system was going to operate is obviously changing. We're going to talk about some of those today. But even the politics of healthcare is changing. And what do I mean by that? Traditionally, government-funded programs, Medicaid, Medicare's been more bipartisan, but Medicaid and even the ACA, Obamacare, have been, particularly exchanges, have been things that Democrats have pushed. And frankly, the prior assumptions are that Republicans want to downsize those programs because they view them as entitlements. And that's just been been the traditional view. But what's interesting, I think the politics of healthcare are changing. What do I mean by that? I think one of the biggest questions is what's going to happen with this budget that's being debated right now. And obviously, the Republicans want a tremendous tax cut, particularly for the upper class. And there's been a debate about how do they fund that. And obviously, cuts are one way they fund that. And the thinking has been that Medicaid is on the chopping block. And I think it's still a real concern for sure. But the interesting thing is that Trump in the last week and his pollsters even in the last week announced that, shockingly, cuts to Medicaid are not being received well generally. And in particular, what's interesting, are not being perceived well or received well, the idea of cuts by Trump's own voting base, which is interesting because that's, you know, traditionally not been the Republican view. But why is that? I think, frankly, the politics, the demographics have been changing of who's supporting Trump. It's a lot more working class folks. In the last election, you saw a lot more folks who might be served by Medicaid. And so Trump's pollster even came out last week saying the idea of cutting Medicaid is not popular among Trump's own voters. And as a result, that poll was done between the last week of March. And as a result, this past week, you actually saw Trump saying he will not cut Medicaid. He will not approve a budget that cuts Medicaid. Now, he has said that they will look at fraud, waste, and abuse, which is a popular term they've been using to sort of, I think, make cuts sound better in Medicaid, but he's not going to cut actual Medicaid dollars. So we shall see. I thought that's really interesting, a total shifting landscape and how you think about who supports what when it comes to healthcare. So there's another add-on to that story, but I'm curious, just first, let's stick with Medicaid because it's really impactful for a lot of our companies. I'm curious your reaction, Halle. I've been trying to think about it, take my Bessemer hat off, my investor hat on, like, how do I think about this as someone who thinks a lot about politics? And I just think the landscape is different nowadays, and it's going to be interesting to see how this battle gets waged.
Yeah. So, you know, I had that interview with Dr. Rajay Bhatniji from Waymark a few weeks ago, and we talked about the KFF health tracking poll. It must be one earlier. It might have been from the beginning of the year that fewer than 1 in 5 adults wanted to see Medicaid funding decreased. And most people, Americans, I don't believe that this poll separated by political affiliation, but most people really think that funding should stay the same or actually increase. And I think the reason why there's so much support is that 1 in 5 Americans are covered by Medicaid. And so almost half of all births are covered by Medicaid. So folks know they either have been on Medicaid or they know someone who's on it. And especially folks in small towns and rural areas that are probably more likely to lean to the right. Yeah, and so, totally. You know, I'm glad to see them voicing their support of Medicaid. It's incredible that it would even be considered on the chopping block, but that they can voice their opinions and that the administration will hopefully listen.
Yeah, it's going to be fascinating to see how this plays out because it's put, like Josh Halle, who is probably as right can get, the senator from Missouri. He's been very adamant. And there are a few key senators in what you describe as red states who've been adamant that this budget process cannot touch Medicaid. So I'm really interested to see how this plays out. I hope it plays out favorably because we have a lot of companies we've made a lot of advancements. I'd say the innovation economy in addressing Medicaid, right? Which for a long time had been overlooked by a lot of people in, generally, and even in our ecosystem, because, you first look to Medicare and commercial because rates are better there, right, in terms of reimbursement. But there's been a lot of great companies that have been built on trying to improve the quality of care, even the cost of care in Medicaid. So massive cuts will impact the progress that has been made. But on top of that story, I saw another story, Halle, which was even more interesting, I would say, in that there was a recent KFF you highlighted. The Kaiser Family Foundation just released a report that showed that, and this is not surprising again to your point, but ACA growth is tremendous in red states. Actually, they looked at the growth of ACA enrollment across different states between 2020 and 2025. And states won by Trump in the last election saw a weighted average growth of 157% in terms of enrollment in ACA plans, while states won by Harris saw growth of 36%. The overall market is growing 113%. So we've talked about how ACA is growing. But again, going to be really interesting to see how that impacts, the whole debate going around enhanced subsidies and whether we keep enhanced subsidies in ACA. And you even see, if you look deeper, Project 2025, which is as right can get, we know, in terms of some of the recommendations. They even say they don't necessarily say we should chop the subsidy market. What they say is we should separate out the marketplaces from those who are subsidized and those who are not subsidized, because the subsidies are increasing the overall cost, but you should treat them as two different markets. So even some of if you read the policy papers, it's a nuanced argument, but they're actually sort of making the case that, maybe because of the popularity of ACA and lots of people, to your point, who have been accessing it, who are in Trump states, maybe cuts to ACA won't happen, which is just wild to think that those two things that I would have prior thought are, oh man, these programs are done in this new administration, right? Are now really being debated about what to be done. It's a wild time out here in terms of. It's
so wild. I kind of two thoughts or questions around that. I mean, one is, the ACA is Obamacare, right? And so when it came
Obamacare.
out, right? Let's call it what it is, but perhaps that association has gone away. And so people now recognize the value of having a marketplace where they can get insurance. But the other thing is, you think about the demographic of people who need to buy a plan on the ACA. These are independent contractors, small business owners, basically anyone who does not qualify for Medicaid and Medicare or, have an employer that covers it, right?
Yeah, under 50 employees. Yeah, the marketplace. Yeah, and then tons of individuals across we know it's grown 113%. So tens of millions of individuals are accessing the plan. And to your point, the subsidies apply to those folks who, by definition, are in lower income, right? That's why the subsidies were created, to help lower income Americans buy health insurance. And so, again, just interesting times. I think I have a vested interest in how this plays out personally and politically, but I would have never thought that I would have been thinking about the shifting landscapes here. So
as I think we talked about before, I also would have never thought that Republicans would be buying electric cars, but here they are with their Teslas. So
there we go.
The world is upside down.
Yeah, the world is an interesting and sometimes scary, very, very, very scary place right now.
Oh my gosh.
All right, over to you, Halle. Next story.
Our favorite HHS director, Robert Fluoride Kennedy, has made autism really the centerpiece of his agenda, and he's calling it a growing epidemic. He's claimed that it's preventable. And most recently, he said that his research efforts would, by the fall, pinpoint its cause, which he is insistent that it is these environmental toxins. He also, or NIH also, announced this autism registry, and that just really, all of these things kind of all happening over the last couple of weeks have really kicked off this firestorm amongst researchers, doctors, people with autism, caregivers, et cetera. But I think what he said He said people with autism will, quote unquote, never pay taxes. They'll never hold a job. They'll never play baseball. And that was like, I think that was the straw that broke the camel's
disgusting.
back.
Yeah.
It's really gross, but is really catapulted autism to the spotlight, and everyone is talking about it. And we can talk about kind of his take on it, but I actually would rather chat with you about a TV show that I love, and they just released season 3, which was ironic in the timing, but it's called Love on the Spectrum, and it's a dating show where the cast members are real people with autism who go on dates with other neurodiverse folks. Have you seen the show?
Okay, Halle, we do these podcasts, and what I realize is you have such a better life than I do. Like, you're so much cooler than I am. Like, every time you say, have you seen the show? The answer is I have not seen the show. I got to see the show. By the way, this is Inside Out. You too, right?
Inside Out, yeah.
That, which I loved. As you know, we talked about that episode. It made me cry, that movie. But I haven't seen this. I will now watch it. Thank you. But
You're
tell me
gonna
about
love it.
Tell me about it.
You're gonna love it. And there's actually there are 2 cast members who are based in Boston. So you're going to love it.
Yeah.
So
Yeah.
one of them is this young woman who is obsessed with the tea. And she's like, that's her thing. Like, a lot of folks on the spectrum have an interest, a special interest that they go really deep on. And hers is the tea. And she does these tea parties. She just wants to ride it all the time. And she's just she really wanted to find a partner who'd want to ride the tea with her. And it's just so sweet. It's a really great show. I think it's really helpful to just recognize that autism is a spectrum, and folks, I mean, they are as diverse in personality as a neurotypical person would be. But the one aspect of the personalities that I have found most endearing is just the complete, direct honesty. Mm-hmm. So they will be on a date, and, one of them will be like, well, what do you think? Like, are you enjoying this date? And the other one will be like, not really. I think we should just be friends. And it's just like, there's just no games. These cast members are just so honest and transparent about how they feel. And a lot of them fall in love, and others, it takes a few dates in order to find someone that they click with. But it's really, I don't watch any dating shows except for this one. So
I love that.
I recommend. And the timing, I think, is perfect.
I watch. Well, speaking of playing games, I cannot not talk about RFK right now, because it's fine. This. I'm sorry. I'll watch your show. I'm going to watch the show. I promise. Okay. But I mean, this. Okay. First of all, let's. I've tried to see the positive, and I think the whole MAHA movement, which is separate from this issue, like I think there's validity to trying to just improve Americans' health and look at lots of healthcare related and non-healthcare reasons why, we have a lot of growing chronic disease, right? But when it comes to this issue, and again, let's try to see the positive. It would be great if there were more funding and trials to be done in studying autism in a real scientific based way, right? Like, I understand the idea of registries and why is my data being used, if you had an autistic child, if you were autistic yourself, like, I understand the sensitivity around that, but registries, there are good sides of registries if they're well done and they're truly private, because it's to study populations over time. And we've seen in diseases like oncology and neurology diseases and cardiology, the benefit of registries. But to set a goal, first of all, the way he cast aspersions and made blanket assumptions about people who have autism or on the spectrum or neurodiverse, those are just disgusting words. Like that, come on. Like, how do you start as the leader of health? How do you start off saying that? But then,
right. And generalize something that's just it's not true.
It's not true. And also, but the thing is to set a goal of September to it just falls completely flat.
That's
and
how science works.
It's like a games. That's not how science works, right? You have to study something like this in a rigorous methodological longitudinal, which means time. It doesn't mean months, it means years. I would be fine with that. I've did some research when you put the story forward. There are lots of different autism and neurodiverse organizations that said they would be fine and want more resources and funding to explore autism. But to make baseless claims about how, that it's preventable and that, there's no proof that it comes from an environmental toxin, which of course, given his history of being anti-vaxxer, people go there. And I get why, because he has been clearly that. It's just a problem. And then on top of that, your administration that you're leading has already made massive cuts to the organizations, CDC and NIH, which frankly are the ones in charge of doing this research. And unfortunately, as you and I know, autism has not been on the top of the list. It's been areas like oncology and other areas where lots of funding goes to. So guess what happens when you cut the staff and the resources for those organizations? Like, I unfortunately think autism, while Kennedy's trying to promote it, I still think it's not, it's not going to get the funding it needs to do the research that we need to actually look at this longitudinally and science-based. And I can't believe it. I can't believe it. And it's really concerning, because I worry that there's going to be decisions made and proclamations that just aren't science-based.
Yeah, I mean, we've heard the myth of autism being tied to vaccines for so long, and it has been
debunked.
Time and time again debunked. And to kind of have someone at that prominent position bring it back and give it some legitimacy is quite scary. And now we're seeing the measles outbreak, which is quite terrifying. So, it's dangerous.
Yeah.
It is. So watch the show. We'll talk about it next month.
Because it'll at least still make me happier, I think.
Yeah. Well, and I think it's also just like, I don't know what RFK thinks the lives of folks with autism.
He should watch the show. Yeah.
He should watch the show. These are wonderful people living wonderful lives, and they're wired a little differently and think a little differently. But actually, there are a lot of aspects of it that I think are preferable to the neurotypical personality trait. But I think dating would be a lot easier if everybody dated like they date on the show.
I love that. Well, I'm going to watch it.
Yeah.
All right. Next story is a really interesting one. We've talked about PBMs. We've had guests on who are building companies in the PBM space. And frankly, one of the next episodes I'm recording is with Patrick Conway, who actually was just announced as Optum CEO, but before that was the head of Optum RX, which is the Optum and United's PBM. But the story this month I want to talk about was really interesting, which is Arkansas, the state of Arkansas, again, who the governor there is Sarah Huckabee Sanders, who people probably know from the political world, Trump 1.0 press secretary, and a Republican, to be clear. But she led a charge, and the Arkansas legislature followed, to adopt a new law that will prohibit a PBM from having both a retail and a mail order pharmacy presence in a state where they also serve as the pharmacy benefit manager. And this is really interesting because, frankly, Arkansas isn't the only one. There was congressional legislation introduced that similarly would prevent PBMs from having a pharmacies. And there's been legislation in all 50 states around regulating PBMs. So lots of action in the PBM space. The PBMs have been in the crosshairs, as we know, because they're viewed as a middleman in a space where there's just sky-high drug prices. And the argument basically of that proponents of this law that passed in Arkansas would say is that, frankly, for far too long, by having a PBM own a pharmacy, it's basically meant that the PBM, who controls where drugs can be filled and controls the reimbursement of those pharmacies where drugs are filled, would refer and provide preferential treatment to their owned pharmacies, right? So instead of going to the local, getting your script filled at the local independent pharmacy, they would either restrict you to only be able to buy the drugs at the PBM-owned pharmacy, or they would provide better pricing, preferential pricing to their own pharmacy and higher pricing to the independent pharmacies, and thus making it hard for the independent pharmacies to exist. And as we've seen, independent pharmacies across America, often which are, again, in small and rural areas, as you've pointed out, making business and, frankly, hard for them to exist. And a lot of independent pharmacies have either gone out of business or have been acquired, as we know, by the larger PBM-owned pharmacies. So a really interesting piece of legislation. We could talk a lot about the details.
Very interesting,
but
right?
I'm curious if you saw the story. There are some counter arguments of why this might not be a good thing. So curious your take, Halle.
Again, the world is upside down. Seeing this from a red state is fascinating because this is exactly what was on Lena Khan and the FTC's radar under the Biden administration, right? Like they put out that huge report that got a lot of attention, and rightfully so, because it is anti-competitive. And so, this is an experiment. It'll be very interesting to see how this plays out. I think I saw that CVS was not happy about it. Were they saying they were going to have to shut down some of their outlets? But in my mind, like, this is a great way for us to experiment with what it means to kind of unbundle the PBM stronghold on the drug market and see what happens.
Yeah, totally. The data actually suggests that in Medicare, right? Medicare basically mandates that any willing provider you can go and get your pharmacy script filled at any willing provider, meaning there aren't these restrictions, right? But what PBMs do in the commercial space is historically have created restrictions or preferred networks or preferential pricing. And the data is pretty compelling as to why this law that was passed in Arkansas should exist, because from 2017 to 2022, commercial members who face these restrictions filled almost 70% of their scripts at PBM affiliated pharmacies where there were these restrictions, compared to only 28% in Medicare Part D. So that was found in that FTC report that you referenced. To be fair, Halle, the obviously you said CVS, and we know Optum and others were strongly against this. Like, their argument is, they'll say, and they said that they're going to have to close down their pharmacies in those states. And a lot of those pharmacies are where they prescribe high cost biologics or infusion or provide home therapy for people who need it. And oftentimes that's in rural areas. Now we can say that that's because they acquired the small independents, but they're saying that this is going to create more of a healthcare desert. So, it's just I saw a dialogue on, our favorite site, Health Tech Nerds, where there was a good give and take around this issue of like, maybe this, while a lot of people probably support this, there could be some unintended consequences where it leads to actually more medical deserts, if you will. And so it's going to be interesting to see how it plays out and who fills that gap, if that gap will need to be filled in the state of Arkansas for sure.
But it's interesting that they said they would have to close pharmacies versus have to close PBM business. Like, why? You know what I mean? Like, does that not say something that the PBM business is too lucrative? Because if you think about actual value added, pharmacies add way more value than PBMs, in my opinion.
Yeah. Well, my question for Patrick was going to be, well, why do you actually have to close the pharmacy? Like, maybe the pharmacy, you can keep the bill doesn't say, maybe you can keep your pharmacy open and just like have it be a separate pharmacy where it has the same rates and the same pricing and the same network as existing pharmacy. I don't actually know the details of the Arkansas law, but it would be interesting to say, well, maybe the pharmacy just needs to compete and there can be no preferential access, no preferential pricing. It'd be interesting to see how they would fare in that market. Now, maybe the law makes it that they have to close the pharmacy. I was going to talk to Patrick about that, but it's like, why not just compete on level playing field and see how you do, right?
We'll see if his legal team lets him answer that question.
Yeah.
But I'm looking forward to tuning into that episode. That'll be a good one. Awesome. Well, I have an interesting one. Researchers are suing academic publishers. So these researchers, academics, they filed a huge lawsuit against the 6 biggest academic publishers, alleging that they operate a cartel that violates, again, antitrust laws. And, I actually wrote a piece on open access before, and it's something that I had put in my book and then kind of took out. So it's not in there anymore. But I spent a lot of time trying to understand this market, because when you talk to researchers, it is like one of their biggest frustrations. And when you think about it, the industry of academic publishing is wild, right? The majority of academic research is published in these journals that are controlled by just a few commercial publishers. It's a $19 billion industry.
It's amazing.
And they have higher profit margins than tech companies like Google and Apple and Meta. And I think the best way to kind of describe the flaw in this model is it's a triple pay system, because our tax dollars, we fund the basic research that's happening. And then the peer review that happens is on the researchers' time, because they're unpaid for it. And then we are also then buying the final product. Those universities have to like pay to read it. And so they don't even get free access to the journal as researchers who submit articles or peer reviewers who volunteer to peer edit. And so, it is kind of at this boiling point now. So I'm excited to see a lawsuit, and I don't know if it will go anywhere. It probably won't, but it's exciting to see this kind of come to the courts. But I'm curious, do you think that there's an opportunity for founders here, or is it an opportunity for universities to have their own journals that are not for-profit commercial publishers, kind of their own thing?
Listen, I'm back in the early part of my career, I did a lot of life science investing, and we at Bessemer have a life science arm. So I spent, I've read a lot of peer-reviewed articles in my life, but I hadn't really thought about this issue until I met a company called ResearchGate, which is actually German-based. It's received a lot of venture money. It started, by the way, Halle, about more than a decade ago. Yep. But they're doing exactly what you want, which is they are like an open access platform. Think about it as a social network designed specifically for scientists and researchers to facilitate the sharing of papers, enable users to ask questions about it, and help researchers find collaborators within the fields, and actually like just open source the entire research community. Now, the two, I met them a long time ago and liked the concept a lot and spent a lot of time with the company. But they too, I haven't caught up with them in a while because they've gone on and been very successful and raised growth rounds.
How do they make money?
Yeah, well, they make money as a lot of these folks do, is thinking about how they can actually use some of the data that's found and the insights found into life science companies. That's one of the ways that they make money, and they benefit from sort of advertising as well, right? And some paywalls, but they too have been sued by these large journals. When I was like, oh, the Halle story reminds me a lot about ResearchGate, and then I look online, and they've been sued by the exact same companies that you're talking about for violation of some of the various copyright laws that these large publishers have, right? And so this is a company that's trying to do exactly what you've done, and actually has had success in the venture and sort of commercial stage, but they too are facing this. I think there is an opportunity for founders. Should universities do it? I don't know, because one of the benefits of reading some of these journals and publications is that you kind of view them as the best of academic research. It's not just from Harvard or MIT or whatever CHOP. It's like you go and see the best papers when it comes to oncology or whatever, cardiology, whatever area you're looking at. So I do think the curation aspect of that is worthy, but I see the point. I didn't realize how this industry worked until you highlighted this story for me. So it was a really interesting read. I encourage our listeners to actually read your post and then to do their own work and understanding this sort of very, as you say, the triple pay aspect of it is concerning for researchers themselves and even the universities.
Yeah. It's accessible to the layman, right? Like when you go and you have a rare disease and you're like, here's an article on it. Oh, but it's like behind a paywall.
Yeah. Yeah. Well, one thing that's sort of similar, it goes to this sort of like, okay, so lots of these companies benefit from tax dollars. I went to a really fabulous AI symposium, health AI symposium, as I think I referenced it, put on by Shaper Capital, Travis May out in San Francisco. And they had this panel of, it was awesome. They had a panel of the 3 past FDA commissioners. And one of the things that one of the commissioners said, I think it was maybe Stephen Hahn, but or maybe it was Rob Califf, they made the point that pharma companies obviously receive a lot of federal money, right? NIH money to fund their trials. And they created PubMed where people can see, all the trials that are ongoing, right? Which is used to be just totally unclear how to find that, and honestly probably has benefited patients because they can go see trials that, as you said, might relate to a condition they have or that a loved one has. And the positive results of those trials are published in these papers, right? Because pharma companies want to get them out there because they need to get them peer reviewed, and then they need to get them as part of the approval process. But the point that one of the commissioners made is the negative trial data is never published.
Yeah.
The pharma companies own that as trade secret, right?
Yeah.
But there's a lot of value in the negative trial data as well. It's almost equally as valuable as the positive, right? Because you can then see, okay, what iterations could be made on a target, maybe it was the wrong target, or on a molecule, maybe you could tweak the molecule. And the question that the commissioners raised is, should the negative trial data be published as well for the benefit open access for the benefit of those who fund it, which is, our taxpayer dollars. So it's not exactly related to your story, but it made me think about that.
But it's actually true across academic research as well. So there was a study that found that studies with negative or null results take several years more to be published, if at all, compared to studies with positive results, because these academic publishers, in order to make money, they have to prioritize what they call this impact factor.
Yeah.
And that is basically how often an article is cited. And so if an article, it has breakthrough positive results, is more likely to be cited. So those sort of studies create this, what is a publication bias. And so the problem is it just gets reinforced because any study that goes and aggregates data, like a systematic study, like what Cochrane does, for example, which they do such a great job. And I love how they put it in plain English so I can understand it. But when they aggregate data from all these other research studies, their results are then distorted because all of the findings that they have, all the studies that they're citing are going to be underrepresenting any past negative or null findings because those studies are less likely to be published. So publication bias is certainly a real problem.
To your question of is there an opportunity for founders here? I think there's an opportunity kind of similar to a ResearchGate or, obviously it's a huge field, $19 billion. So there should be multiple companies and probably subsectors that companies are built around attacking the problem you identified. But then I was thinking, gosh, think about a company, if there's some sort of business model, I don't know exactly what it is, to figure out all the stakeholders and the negative findings and how do you incent them to share that data? That could be a huge company. Don't know exactly what that looks like, but I think that's an opportunity for founders.
But how great would that be? I mean, you could think about how much wasted time you could avoid by being like, hey, I already went down that route and here were my findings.
Totally.
But instead, how many times are we going down the same paths because no one has shared the negative results? I mean, this is true not just in research, not just in science, but I think in digital health as well.
Yeah, this is life. Yeah. Yeah, you learn most from your, failures, right? I mean, honestly, you learn in life, you learn most from your failures and how do you deal with them and what do you take from them?
You do. So, I'd actually I'd love for us to find more founders whose companies did not work out to come on the show and share their key learnings.
100%.
We need to do
That's
that.
a call to action if you're listening.
Yes, reach out to us if you were willing to share your story and help others avoid the mistakes that you made.
100%. All right, our final story. This feels like we're breezing through these, and these are all really good, meaty topics, Halle. So I love this month. A little bit of plug here. I apologize. Little self-serving, but I want to just pay tribute to my awesome colleague, Sofia Guerra, who we've had on the podcast. I know you've interviewed her in the past. And this month, Bessemer put out, and we'll put it in the show notes, what we called the Healthcare AI Adoption Index. We co-authored a study alongside AWS and Bain & Company. They were our great partners in this work. And the impetus was, we've done a lot of thought leadership work, and others have too, on AI. And this time, we as it relates to opportunities for founders, and this time we kind of wanted to flip the script and talk to buyers, right? To the executives and decision makers at large healthcare enterprises, specifically healthcare providers, insurance companies, and pharma companies. We talked to over 400 healthcare executives. These are C-suite level leaders who are the decision makers and buyers for all of this amazing technology, products and services.
400. That's nearly comprehensive of all the buyers.
Bain & Company was nice enough to partner with us in this work, and literally ran what Bain & Company does, along with lots of other great analysis, but they ran a survey, and we asked 50 plus questions. We've got crosstabs, all the data. But anyways, we published this report to really help founders, on the one hand, understand how these decision makers are thinking about procuring and adopting and implementing AI solutions. And then on the other hand, also to provide insights into decision makers around how they can partner with both startups and other vendors in advancing their AI strategy. And some of the insights were fascinating, Halle. What we found is actually, and not surprisingly, and in some ways it's surprising because you and I have been in healthcare technology for a long time, the pace of interest and adoption of AI in healthcare is far eclipsing any other platform that has been put forth for our industry. And the study showed that there is real meaningful interest and action being taken on, so that's actually nice to see. It's not like we're just hoping and dreaming in the startup world. This is a reality. And the greatest example of this, Halle, is actually the AI scribe space where, the pace of adoption is like 10x the pace of the adoption of EMRs. Already kind of 3 years into the health AI scribe go-to-market efforts, over 80% of the people that we interviewed, these would be mostly providers, are in the process or are already implementing an AI scribe. Like, that's crazy. Going from 0 to 80% adoption. This is statistically a significant survey. So, like, amazing to see that. That was a positive on the one hand. We didn't just look at scribes. We actually looked at 60 jobs to be done in healthcare. So these are like specific areas where AI can be applied to workflow or processes that are done in healthcare across pharma, payers, and providers. So it's not just scribes. We basically charted each in terms of what the pain point is, perceived pain point from the actual end buyer, and then where they are in their adoption cycle. Are they have they not even have a strategy around it? Have they started to do RFPs? Are they in the pilot stage? Are they actually implementing? And then we basically created what we call a health AI DX diagnostic score to understand where you are on the pain point versus adoption, right? And so if you're a startup, you probably want to be focused on something that's high pain point for the end user, but early in the adoption because there's opportunity to grow. But if you're a buyer, you obviously want to be high pain point and probably have other people have adopted, so you have some comfort in that it's actually worked for other users. So very interesting study. I'm sure you've read it. I'm curious if you had any other takeaways from it.
Yeah. Well, congrats to the team. You guys always do such a great job on this stuff. And we need to get Sophia back on the show. She has to share more. So, I'd love to talk about what you guys learned around the evolution from a pilot to like full integration, because I know that not every pilot ends up being a paid partnership. So what did you guys learn there, and what can like founders keep in mind as they celebrate landing a pilot?
Yeah, I think, in fact, we found that only 30% of AI pilot programs actually move into production. So you're right.
30%. So the vast majority just stay in pilot land.
Yeah. And so what we really found was there are a lot of stakeholders, right? There are governance committees, there are users, there are buyers, and really, navigating the relationship side in terms of building trust was a word that we heard a lot. And then the other thing that can really help is being very specific with your buyer about how you're going to measure the outcomes, right? And that really is important when you sort of are shaping the RFP and, in the early procurement process. Like, the companies that did a better job of being clear about how outcomes are going to be measured, not surprisingly, led to more likely of actually having success moving from pilot to full deployment. But the other interesting thing, which is not something that we went in thinking about, two interesting more insights is, one, a lot of buyers said that they wanted to co-develop solutions with early stage companies. And so I think the idea of, I know, because the thing you hear is, oh my God, is that going to be,
can that scale?
Yeah, can that scale? Are you just going to be doing custom development? But frankly, we've been seeing this a lot, Halle, in the world. It's. I think people are in healthcare, and Palantir's been leading the edge on this, not just in healthcare, but in other industries. This forward deployed engineer concept, where you're actually literally co-developing a solution with your buyer. I don't necessarily think it means customization. What I think it means is, you may have one product or a set of products that this is what I encourage startups to do, that you have codified and you believe strongly in, and the ROI about, and but you're sort of making it feel like it's co-development with your customer by putting, whether it be customer success or an engineer in partnership with their team. That's what I think is the opportunity when it comes to co-development, not necessarily, custom built solutions for each health hospital. It's what Epic has done. They put a big team at each, they just deploy CS folks within the four walls of the hospital. And when you mentioned Epic, Halle, I think the other interesting takeaway we found, and we'll get Sophia on to talk more, is only 15% of the solutions that are out there in the world and being used by health systems are actually provided by startups. So we, startups, when we're venture capital, we always ask about competition, and startups often include other startups on that competitive slide, that 2x2 that we've all seen, right, in the deck. But, it's not just Epic, it's other vendors, right? It's actually, homegrown solutions built on top of some of the cloud platforms, or, maybe some of the LLM providers. So the majority of actual solutions are not startup backed. Now, that could be an opportunity, but it's also a challenge. And so thinking about the diversity of the competitive set and how you sell as a startup against not just other startups, the incumbents, which, we know healthcare is an incumbent dominated institution. I would have thought in this AI first world, the classic startup, which probably has better tech, would win, but it's proven to be true again that incumbency advantage is real. And frankly, I just recorded a podcast that we're going to release in a couple of weeks with Eric Larson. It's fascinating. He's a really thoughtful mind when it comes to healthcare and AI. Used to be the president for a long time of the advisory board, and he's just written so much good work around AI. We talk a lot about this, about who's going to win this war. Is it going to be the incumbents or is it going to be the insurgents? And our study shows that in the early days, the incumbents are still being looked to help develop these solutions.
Yeah. Well, you said the key word earlier, which is trust. And so there's a bias with trust with a company that's been around for a while. And with the startup, I think a lot of buyers are weary of the reliability and what happens if they run out of funding. And can I depend on this company to have all the compliance done? So when it comes to trust, I do think that if that is one of the key words that you kept hearing over and over from the buyers, then I think startups really need to look inward on how they position themselves as a potential reliable, trustworthy partner, because startups are inherently very risky.
Yeah. Well, if you are a founder, you should read the report. There's actually literally, we catalog every single job to be done. I think there's a tremendous opportunity in each one of them to develop companies. And so hopefully it's a useful read for both founders and for decision makers in this ever-evolving health AI world.
Well, listeners, check out the show notes below, and you can check out this article as well as all the other ones we discussed. Well, Steve, we did it. Another month gone by, and we only talked about Trump a little bit.
My heart rate is at a decent level right now. Thank you, Halle.
I know. All right. Well, I'll see you next month.
We'll see you then.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Halle Tecco and hosted by Michael Esquivel, Steve Krause, and Halle Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.
Find yourself looking for a new job or change in career? Monster.com is here to help. We are not only here to bring you job postings, but also AI interview prep and salary tools, expert career advice, and top-notch resume services. We've got everything you need to land your perfect job fit. Discover the magic of finding the ideal job with Monster.com. Your future starts now. Visit Monster.com today. Your next job opportunity is just a click away.
At Arizona State University, we're bringing world-class education from our globally acclaimed faculty to you. Ranked #1 in innovation for 10 consecutive years and #2 among public universities for employability. ASU isn't just ahead of the curve, it's creating new paths to success. Earn your degree from the nation's most innovative university. Online, that's a degree better. Explore more than 300 undergraduate, graduate, and certificate programs at asuonline.asu.edu.